So shock is an impaired cell metabolism as a result of inadequate tissue perfusion. You have several types. Cardiogenic, which is basically when the myocardium can't meet the needs, the oxygen demands to the body. We want to treat with positive inotropics, which act on the sympathetic nervous system. Those drugs are dobutamine, dopamine, epinephrine, Primacor, and Inocor. When we're talking about dobutamine, we want it less than 20. If it's over 20, you want to switch it to epinephrine. In doses when it's less than 20, I believe you also, or less than 10, you also use it for renal perfusion, so that's a good thing. Then you have dopamine. Dopamine's side effect is tachycardia. Dobutamine is hypotension with reflex tachycardia. And Inocor has a side effect where it's thrombocytopenia. Next we have hypovolemic shock, which is obviously an imbalance of volume. Definitely the first thing is fluid resuscitation. You're going to want to initiate 2 large bores of normal saline, 2 liters within 2 hours usually is the protocol. Some of the replacement fluids we use are colloids. They expand plasma volume. Colloids include albumin, dextran, Hespan, the albumin factor, proalbumin factor. We also talk about SPA, which is the salt pore albumin. There's 5 to 25%. I believe the 25% is the SPA. Blood and blood products. We're talking about whole blood products, whole blood, fresh frozen plasma, platelets, all that other good stuff. The best choice in the blood product when we're talking about shock is fresh whole, because it has several things. Next is vasogenic distributive. It's a broad category, and it basically has to do with decreased peripheral vasoconstriction. There's a relative hypovolemia. The fluid's there, it's just not circulating as efficiently as it needs to. And there's issues with the amount of blood volume versus the size of the vascular bed. You have neurogenic, anaphylactic, and septic, which fall in the vasogenic/distributive broad category. When we're talking about neurogenic, usually it is a result of something that has happened, like a trauma. It is temporary. We're talking about possible spinal injuries. Spinal anesthesia could occur, something like this, an accident. The treatments we use are dopamine, which maintains the blood pressure. If it's a suspected spinal cord injury, naturally we're going to do getting maintaining an airway, patency, immobilizing to prevent further injury. Early medications in the neurogenic shock category increase doses of methylprednisolone, and a symptom that you're going to see in neurogenic shock is bradycardia. Anaphylactic shock is obviously a result of a hypersensitivity reaction. Again, fluid resuscitation is ideal in this category. We're going to treat with epinephrine. Normally when there is anaphylactic shock, we go right for EpiPens. Albuterol, because there is bronchoedema, bronchospasms, you want to also do albuterol. Benadryl, it's an antihistamine. It's going to work great. And then you have the hydrocortisone as well. Next is our septic shock. With septic shock, there's so many endotoxins in the system, or the toxins, they're causing the vasodilation, and it's not letting the fluid circulate as it should. So fluid resuscitation is ideal, typically crystalloids, colloids, and blood products. Antibiotics, you want to do 2 or more, because we want to get started on that quick, try to rectify the situation. Then we want to identify and remove the source. Respiratory support and mechanical ventilation will sometimes be needed in severe states, I imagine. So next we're going to move over to our shock signs. Kind of just going by body systems. Early in shock signs, you're going to see a patient who is anxious, who is restless, a little bit of apprehension. As they progress, they'll have difficulty concentrating, lethargy, and possibly coma. Pulses will begin to be very rapid. The tachycardia is going to be experienced in the heart rate. Then it's going to really change to thready and weak. The exception is neurogenic. They do begin with bradycardia, for heart rate. Blood pressure, you'll see that postural hypotension where there's a 20 millimeter of mercury difference from sitting to standing. And then as it's going to also go into that narrowing of blood pressure, that classic V I think we talked about in pericarditis, 20 millimeters mercury as it progresses. In the late stage, you're going to see the diastolic blood pressure decrease. In respirations are going to be rapid and shallow. Metabolic acidosis, obviously there's some hyperventilation going on. And in the late stages, you're going to hear crackles due to fluid shifts. Skin, initial presentation will be cold, clammy, and pale. And in the late presentation, it'll be a diaphoresis, cyanosis, and mottled. The exception is anaphylactic shock, where the skin is flushed and warm early, and it's dry and pink, and that's probably due to the inflammation process. And then hypovolemic, you'll see dry, poor skin turgor. Again, it is a fluid volume deficit. Pupils in the early stage will be dilated. Late, they'll be sluggish. Urine, typically a finding in shock is less than 30 cc's per hour. However, as it progresses, it may even get down to less than 20 cc's per hour. And in the final stages, late, you'll have no urine at all, anuria. It's important to note that if you do see the patient in less than 20 cc's in the hour, wait a second hour to obtain a full assessment before you call that doctor. It may be isolated insulin, and you just want to make sure that you're calling the doctor with as much exact information as need be. Bowels. In the early signs, you'll have diminished bowels, and in late, you'll have paralytic ileus, which means it'll be paralyzed pretty much. There'll be nothing going on. The jugular veins will be presented flat, and the exception to the jugular vein is cardiogenic. You'll have that distension and the cardiogenic shock because of the right-sided heart failure that is going on. And that basically concludes my presentation on shock. Again, this is more for the benefit of having a review for finals. And that's that. Next, we're going to move into oral hypoglycemics. Another part of this test is actually our diabetes portion. Oral hypoglycemics are generally used for the type 2 diabetes patient. There's several of them, several mechanisms. We're going to talk about them now. First one is sulfonylureas. Basically what they do is they stimulate the pancreas to secrete insulin. It is administered before meals. And the ones in that category are glypyride, glipizide, glimepiride, and glucovance, which is a combination of a sulfonylurea and glucophage, metformin. It is very good, however, there is an increased risk of hypoglycemia with that drug, but it's been known to be very effective. The side effects are increase in weight, hypoglycemia, and allergic skin reactions. Next, we have meglitinides, which also stimulate the pancreas to secrete insulin. They're also administered before meals, but it's very important to note that meglitinides are structurally not related to sulfonylureas, even though they basically have the same mechanism of action. The drugs listed in the meglitinides category are Prandin and Starlix, and these side effects are hypoglycemia, headache, and GI symptoms. Next, we move into biguanides, which basically decrease the hepatic production of glucose. You see the G in biguanide, so I think, okay, the big G, it's going to decrease the hepatic production of glucose, decrease the insulin resistance as well. The medication in that class is metformin, otherwise known as glucophage. The side effects with those are loss of appetite, abdominal pain, lactic acid buildup for renal patients, so you definitely want to monitor renal patients. With metformin, I would say it's definitely contraindicated with someone who has renal impairment. Also, a big thing with metformin is if any patient who is on metformin goes for dye studies, you want to hold the medication for 48 hours after the dye study, because metformin binds to the actual contrast, and obviously it can cause some damage to your kidneys. So you definitely want to hold metformin after a dye study for at least 48 hours after the procedure. Next, we have alpha glucosidase inhibitors. These basically inhibit the alpha amylase. It also delays the digestion of carbs and subsequent absorption of glucose. The medications in this class are Precose and Glycet, and the symptoms are intestinal gas, abdominal distension with loose stools, and a rare side effect is liver toxicity. Next, we have thiazolinidians, and what they do is they increase insulin action at the receptor sites and decrease insulin resistance as well. So they work rather well, I would think. However, with that come side effects. The medications in that category are Avandia and Actos, and the side effects are abdominal pain, nausea, anorexia, fatigue, increased risk of cardiac events, allergic reaction, and liver damage. Next, we actually have the class that I happen to enjoy rather much. I think it's probably one of the better ones, DDP4 inhibitors. What they do is they inhibit the breakdown of the creatine hormone. They also inhibit glucose. Secretions. They decrease appetite. They promote satiety, and they inhibit gastric emptying. This is a good medication, but primarily because it is a glucose-dependent drug and it's only released when needed, you're going to see a patient who has lower risk of hypoglycemia because it's only going to work in the presence of glucose. The names of these drugs are Januvia and Galvis, and the symptoms are diarrhea, sore throat, headache, upper respiratory infections, and no weight gain. So I know these for a fact, according to someone I talked to. These are very expensive. A friend of mine, her mother takes this medication, and her copay is somewhere around $58 after. So I'm sure it's a highly expensive drug, partly because it is so effective. Next, we have incretin mimetics. And what they do is they stimulate one of the incretin hormones to decrease the glucagon in type 2 patients, or basically it's to decrease it in type 2 patients. And you want to administer it before mornings and evening meals, and it's a subcutaneous shot. The name of the medication is Byetta, and the headache, nausea, vomiting, and diarrhea accompany this medication. Those are your side effects. Next, we have amylin analog, otherwise known as Simlin. This is a synthetic analog of amylin. It slows gastric emptying, it suppresses hepatic glucose, and it increases postprandial satiety. So you get a feeling of feeling full after your meal, which is good. Because of that worthy characteristic, you definitely want to take it with major meals. It is a subcutaneous shot that should be administered in the thigh or the abdomen. You shouldn't do it in the arm because the absorption rate is variable and it isn't really effective in its variable state. You don't want to mix this medication in the same syringe with insulin, and if you're going to take insulin as well as this medication, you want to make sure that you're at least 2 inches apart from the insulin injection site. These side effects include hypoglycemia, decreased appetite, nausea and vomiting, and headache. And that concludes my 13-minute presentation on shock signs, and oral hypoglycemic drugs.